Hello everyone, this is Dr. Humanist again. Let us now discuss about autoimmune encephalitis, that is autoimmune destruction of CNS. So there are two types, paraneoplastic and non-paraneoplastic. Paraneoplastic common cancers are like small cell lung cancer and ovarian teratomas. So pathophysiology, one is directly antibody mediated, that will affect the neuronal surface proteins, that is for example NMDA receptors or voltage gated potassium channel complexes, and then second is T cell mediated, directly cytotoxic T cells will target neurons and cause the damage. So based on which receptors the antibodies are attacking on, we'll get different types of autoimmune encephalitis. Okay, so first type, anti-NMDA receptor encephalitis. It is common in young females and it is associated with ovarian teratomas. Okay, so what are the symptoms will get? Prodrome will be there, like fever, headache, flu-like symptoms. Neurological symptoms like seizures, confusion, memory loss, abnormal movement, and speech disturbances will be there. Psychiatric symptoms also can be there: aggression, hallucination, agitation, psychosis, and catatonia. So associated tumor, you have to remember ovarian teratoma, that is in the 50% adult females. Next is this one, anti-LGI1 encephalitis, that is a subtype of voltage gated potassium channel complex. Okay, it is more common in older men. It targets leucine rich glioma inactivated 1 protein, which is a part of VGKC complex, as I just told you. Clinical features, the pathognomic is facio-brachial dystonic seizures. Okay, there's a brief dystonic movements of the face and the arms, right? Next, it can be cognitive dysfunction can be there, memory impairment, hyponatremia can be there because of SIDH. Next is anti-Caspar-2 encephalitis, which is also a subtype of VGKC complex. So features like peripheral nervous system involvement will be there. CNS manifestation can be there, cognitive dysfunction, seizures, psychiatric symptoms, and there is something called Morvan syndrome, which is characterized by neuromyotonia, dysautonomia, and encephalopathy. Next is anti-GABA receptor. It can be against anti-GABA B or GABA A receptor. There will be seizures, refractory seizures, which will frequently lead to status epilepticus, cognitive decline, psychiatric symptoms, less frequently associated with the tumors. In some cases, only lung cancers has been seen. So anti-AMPAR encephalitis, next one. So AMPA receptors are targeted here, and clinical features like seizures, memory loss, behavioral disturbances, and these are associated with tumors like lung cancer, breast cancer, and thymomas. The last one is anti-GAD65 encephalitis. GAD is nothing but glutamic acid decarboxylase, which is responsible for GABA synthesis, right? So we will get here stiff person syndrome and cerebellar ataxia, epilepsy, and it is sometimes associated with diabetes mellitus also. Clinical presentation we just now discussed based on the type. You will get cognitive dysfunction, seizures, neuropsychiatric symptoms like hallucinations, behavioral changes, movement disorders, autonomic dysfunction you can get, and sleep disturbances, right? Now diagnostic approach, MRI. MRI shows hyper intense lesion in the medial temporal lobe, that is limbic encephalitis, or even in the cortex and subcortical region. So hyper intense lesions will get. Okay, but in early stages and sometimes the MRI will be normal. Okay, now next is CSF analysis, cerebrospinal fluid analysis. What we'll get here is lymphocytic pleocytosis, increased WBC count, elevated protein, and oligoclonal blands. Next is EEG. It will show diffuse slow wave activity. Focal abnormalities or epileptic discharges in patient with seizures can also be there. Okay. Serum and CSF antibody testing. So what antibodies will get against NMDA, LGI1, Caspar-2, GABA, AMPA, and GAD65. So these are all antibodies we can get. Tumor screening. Okay, we can go for paraneoplastic, in cases of paraneoplastic encephalitis, imaging tumor markers. Okay, to see any lung cancer or ovarian cancer, we have to see breast cancer. So tumor screening is important because it is frequently associated with paraneoplastic syndrome. Okay, now coming to the management, first line treatment is steroids. Hydrosteroids, steroids you have to give methylprednisolone 1 gram per day for 3 to 5 days to reduce the inflammation, and then you can go for taper. Then IVIG, The dose is same 2 gram per kg over 2 to 5 days or plasma exchange, that is PLEX. Second line treatment is rituximab. Dose is 375 milligrams per meter square weekly for 4 weeks. Next is cyclophosphamide. Dose is 500 to 1000 milligram per meter square IV, cytotoxic drug that suppresses the immune system. Okay. Next is treatment of underlying malignancy. Okay. Next is symptomatic management, seizure management. You can use anti-epileptic drugs to control the seizures. Okay. So, but they have seen that anti-NMDA receptor encephalitis, the seizures are often resistant to the conventional anti-epileptic drugs. Psychiatric symptoms, antipsychotic medications like haloperidol, quetiapine. Okay. So prognosis, if we see anti-NMDA receptor, it's generally good if treated early, with up to 75% patients showing a significant recovery. However, delayed treatment or untreated cases can lead to severe neurological deficits or death. Anti-LGI1 encephalitis, with treatment, patient might recover well, but some have persistent memory impairment. Paraneoplastic encephalitis, prognosis depends on the early detection and successful treatment of the underlying malignancy. Thank you.